My Favorite Learners is supported by Apex. If you're a CRNA tackling Class A, CE, and CPC core modules, Apex makes pharmacology stick with crisp lessons and exam-style questions you can do anywhere. Build a study plan, track your progress, and learn on the web or mobile. Get 10% off CRNA products and bundles with the code MyFaveLearner at checkout. That's MyFavLearner at checkout. With Apex, you'll have smarter prep and safer patients. Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Today's guest is Becky Motykiewics, DNAP CRNA, a pediatric cardiac nurse anesthetist with over 10 years of experience. She recently earned her DNAP at Missouri State, and her doctoral work focused on pediatric airway education for CRNAs. Becky teaches and presents nationally, serves as a peer reviewer for the Journal of Nurse Anesthesia Education, and created a pediatric anesthesia drug calculator app to reduce medication errors. Becky, welcome to the show. Hello, my favorite learners, and welcome back to another podcast episode. I'm so excited today to be joined here with Becky Motykiewics, who is a pediatric CRNA. Now she's an educator, and she's someone that I would text or call if I had a 5 kilo baby on my table. So thank you for being here, Becky. I appreciate your time today.
I am so excited to be here. I live for peds pharmacology and helping people just feel more comfortable when taking care of these itty-bitty patients that weigh less than your anesthesia machine, maybe even less than your laryngoscope blade.
Yep. I feel like this is such a good topic for any type of learner, whether it's a brand new SRNA or even, a seasoned provider who just hasn't done peds in a while. So I appreciate your expertise today. I have every podcast where the guest starts off with telling us a little bit about your story and how you ended up into CRNA education and academics. So tell us your story.
So I just started a couple of weeks ago as full-time faculty at Drexel University in Philly. I've been doing some adjunct the past couple of years. Shout out to my Fairfield University crew. They are part of the reason I got into full-time teaching. Between the teachers and the students, I just fell in love with education. I am also a super nerd, so I like to dive deeper into subjects, and I felt like teaching was just like the next best step.
Yeah, totally. I'm right there with you. So this is my first academic appointment as well. So we are new to education, but not new to clinical practice. So I kind of annoy myself because I start teaching, and I don't know if you'll do the same, or I just start applying everything to clinical because, one, that's why we're here, right? Patient care. But it's what I'm comfortable with, is applying everything to patient care. So it'll be a great podcast today. So we are going to dive in at this point. So let's talk a little bit about pediatric pharmacokinetics and pharmacodynamics and how they're different than adults. I know you have a little, thing that you say about them not being, everyone says that peds are just small humans. So tell us a little bit about that.
So in your peds rotation, you'll hear over and over and over again that kids are not just small adults. And well, they are and they aren't. I feel like this saying just really intimidates learners. It makes them feel super nervous to take care of these patients. But if you start looking at some of the pharmacokinetics and dynamics, they sort of mirror our elderly patients. And so the things that you apply to some of your older patients, you're going to apply to some of your smaller patients.
Amazing. I really agree. And I think that starting off in peds, I remember my first day at peds, I was at CHLA, and not only was I lost in the facility, but I was lost in giving pediatric anesthesia because it is very overwhelming. However, we can't take those principles of adults and bring it to pediatrics. So I love how you mentioned that. Let's dive deeper into a little bit more about pharmacokinetics. So we're going to go into the ADME, which I did a solo podcast on, basically an overview of ADME. So we're going to start with absorption first. So can you kind of talk about how pediatric patients differ in the realm of absorption?
Absolutely. So first I want to start with, usually when we're talking about pediatric patients, we're talking about the neonates and infants, maybe even toddlers. As they get to about 6-8 years old, they really are more like the adult patient. So most of this applies to the babies, the itty bitty ones. With Absorption, especially PO absorption, the neonate has a higher gastric pH, so our weak bases are going to absorb better, but our weak acids are going to absorb worse. And on top of that, gastric emptying is much slower and variable, so our PO doses of drugs are going to be a little erratic with their onset and hard to predict. Same thing with IM medications. With neonates, it's going to be unpredictable. They have less muscle mass, they have less perfusion going to those muscles, and so it's going to not be super reliable like with the adult patients. And then when we use any sort of medicine on the skin, so transdermal, topical drugs, especially things like Emila cream, the absorption is going to be a lot higher and faster, and so our pediatric patients can have some systemic toxicity that you wouldn't see with the adults because of that rapid rate of absorption.
Yeah, I love that. That is, but the only thing I got to thinking when you were talking about, gastric pH is we don't tend to give a ton of PO medications to pediatric patients in the operating room. However, everybody's been there where we're waiting for the dose of Versed to kick in, giving Versed preoperatively. And it is variable. So that's something, again, we can apply to clinically, and got my wheels turning is like how many times you're like, usually it's about, 5-10 minutes, sometimes 15. It is variable in that stretch. Plus, like, have they spit out half of it when they were fighting their parent, as they got it in pre-op, which is another thing with pediatrics that we have to deal with preoperatively and is specific to peds. So I love how you mentioned that.
Where this really comes into play too is with the Versed PO is the delayed gastric emptying. So if it's a shorter procedure, the Versed's going to kind of linger, and so they may not wake up at the end of the case as quickly as you think they should, or they may be really sleepy and pack you for longer than you would have thought they might.
Yeah, which makes sense too. And I mean, sometimes we don't even give Versed for those short cases. We don't even give it for tonsils really anymore in the practice that I have been a part of because it just delays everything. Yep. Now we can kind of go into the next step, or the next, not phase, but the next part of pharmacokinetics, which is distribution. So I, again, did a podcast on this, but I'm going to do an overview of volume of distribution again. So I talk about volume of distribution in terms of like volume of water, right? Like you have a little glass of water. I have my Stanley here, which is a little bit bigger. And you could have a swimming pool, right? And if you put the same dose in all of those different, or I do like dye, right? You do 1 drop of dye in each of those, it's going to look much different based on the volume of water. And that's kind of how I visualize volume of distribution. And patients that have a higher volume of distribution, like our pregnant patients, because they have a higher blood volume, like things like that, change how we dose our medications and how patients respond to the medication. So can you kind of talk about peds and how their volume of distribution is a little bit different?
Right. With peds, the volume of distribution is one of the things I think plays a huge role in a lot of our anesthetic drugs, because neonates are basically little water balloons. They are just full of water. Their total body water percent is about 75 to 80, which compared to adult is usually about 60. The big thing too is the extracellular fluid in the peds patient is about 40 compared to 20 with the adult. So you just have this large volume of water. This really plays in with our hydrophilic drugs like rocuronium. They have a large volume of distribution in the neonate, so you're going to need an initial higher loading dose of those drugs, so a higher milligram per kilo. Often this will lead to a longer interval, so when you go to redose the rocuronium, you'll wait longer, but the initial dose needs to be higher.
What about protein binding? How are peds different in that realm?
They have a lot less protein binding. They have lower albumin. They have lower alpha-1 acid glycoproteins. So drugs that are highly protein bound don't have those proteins to bind to. So you have more free fraction of the drug floating around, going where it needs to go on receptors to the brain. And so drugs like propofol, benzos, dexmedetomidine, they're going to have higher concentrations of free drug in the body.
Which is definitely important to consider when dosing and redosing medications that are highly protein bound, for sure. Now we can kind of talk about metabolism in peds. And kind of most of our drugs, right, are metabolized by the liver. So we can kind of dive into the CYP 450 systems and how those are different in the pediatric population. So can you give us a little bit of an overview on how they differ in metabolism with drugs?
Definitely. As you can imagine, like most of the systems in our neonates and infants, the CYP enzymes, that's immature, it usually ramps up pretty quickly. So the neonates, it's really low. And then with older kids, even 1 year to 9, have higher rates. So for our neonates, they're not going to process those drugs as quickly. For the older kids, they're going to metabolize them faster. If you're running a propofol infusion, for instance, neonates might need a lower dose per kilo, where our older kids need a higher dose.
Yeah, I love that. These are our recommendations based on the differences in the pediatric population, but obviously you make accommodations according to how the patient responds in the clinical settings. Now we can talk about excretion a little bit. So how is excretion different in the pediatric patient? And again, if you have any scenarios where you can apply this clinically, let us know.
Again, it's going to be immature, weak. The GFR at birth is especially low. It again rises pretty quickly through the infant years. Usually by 6 to 12 months, they're getting more like the adult. But with those neonates, they're just not secreting, reabsorbing as much, and so renally cleared drugs are going to last longer. They're not going to need to redose as quickly. So a drug like rocuronium, some of our other neuromuscular blockers, they're not going to be cleared as quickly, and so you're going to wait longer than with the adult. So where an adult, you might redose your rock every 30 minutes. With a pediatric patient, you might need to redose every hour.
So let's talk about pharmacodynamics. So we'll switch over to pharmacodynamics since we went through the ADME of the pediatric patient. So let's talk about some of the differences in our agents. So let's first go through like the volatile anesthetics. Like how are the pharmacodynamics different in peds for even just our gases?
So our volatile agents are different with peds, where they're going to need a higher MAC than adults. So the minimum alveolar concentration peaks with infants, usually about 3 to 6 months, and then decreases after that. This with neonates is a little lower, although SIVO kind of acts weird, and sometimes SIVO for neonates on paper you would run higher, although I think clinically that's not necessarily the case, but in theory you would need a higher concentration for the neonates. So that's the big thing, is they're going to need a higher MAC. They also have a higher rate of induction, or that rate of rise of the gases, because they have a higher minute ventilation. So the gas is going to go from your machine to the lungs to the brain much faster with the neonates and come off faster. So typically they wake up faster with just the gas than adults. Now you add in other drugs and things happen, but with gas alone, the rate of induction and recovery is faster.
Yeah, that is. Yeah, we always say in peds, or I worked at a pediatric hospital, so I have a fair amount of peds in my background as well. But, the more they cry, the faster they go to sleep, right? Because they're like taking big, deep breaths now. They're really screaming and nobody likes to hear it, but at least they go to sleep faster. Especially, that's what I tell parents to reassure them as well. Like, I know it's...
Same. I tell the parents, if I'm bringing them back crying, I'm like, just know they're just going to go to sleep even faster because they're taking those good, deep breaths.
Yeah, exactly. It kind of reassures them that there is some benefit to this going on. So as you talked about how, MAC values are high and then they kind of decrease, just so everyone listening has a little boards tidbit, the MAC value drops 6% per decade after 40. So if you had a patient that's 60, you should be able to calculate, I'm not going to do it off the top of my head, but at a rate of dropping 6% per decade after 40, that's something for boards to prepare you that is something that you should know. Yeah, I love all the clinical applications. So let's go into opioids. So how do opioids differ in terms of pharmacodynamics in pediatric patients?
The biggest aspect, especially with, again, the neonates and infants, and even more with premature infants, is the respiratory depressant sensitivity. They're going to have more apnea and respiratory depression with opioids. They have immature receptors as well. But the big thing is to watch for apnea when you're giving any sort of opioid to a neonate and especially a premature baby.
We already kind of mentioned benzos, but kind of mention it again. Like how are benzos affect our peds?
Again, they're going to have a prolonged effect in our neonates and our smaller children. Mostly that gastric emptying, but also because of the CNS effects of it, it just lasts longer in our kids. And so you have to be a little careful with dosing. And I say especially that PO dose. So you need to get them chilled to go back to the OR, but not let it last so long that then they live in PACU for the next 4 hours.
Yeah, and again, like weighing the risks and the benefits, right? So like sometimes, we'll be like, oh, this patient, normally we would give Versed to this kid, but they seem really calm and chill. They're letting me hold them. Maybe we'll skip Versed so that they have a little bit shorter of a PACU stay. I've done that. I've done the opposite where it's like, this kid is not going to tolerate, anything. Going back to operating room, it's going to be very traumatic. So we've given, we've all done it, given Versed, PO on a very short case, and just know that that kid's going to be watched a little bit longer or going to be a little bit sleepier in recovery, which again is the clinical picture of how peds decision making and risks and benefits. You're just constantly going through the analysis of risks benefits in anesthesia, but specifically in pediatrics. So I like how you mentioned that.
Yeah, and you can also sometimes get the crazy agitation where it just does the opposite that you want. They just act crazy after the Versed. So usually parents, if they've gone through this before, they're like, please don't give the Versed. Last time they were a monster when they woke up.
And honestly, listening to we always want to listen to patients, right? Because patients, when they come in, they're like, oh, they always get the IV right here. Like, that's like clinical 101. Listen to the patient, but specifically with peds, listen to the parents, because a lot of the times they have insight on things that are going to be very beneficial to the anesthetic plan. Sometimes it can go the other direction, but for the most part, parents, I think there was a research study, I need to look this study up again, where it says, like, generally speaking, parents are very honest about how their kids do and what they do, as opposed to lying to like overcompensate for their kids' behavior. I need to look that study up so I can quote it specifically, but I always reflect on that as a parent myself, in that I am pretty honest with my kids' behavior, whether good or bad. So listening to parents is super key in peds, I think, as well. Okay, let's talk about our neuromuscular blockers, our SUCs and the non-depolarizers. How are those different in the pediatric patient? Specifically, SUCs has a little bit of a caveat as well. So let's kind of talk about that.
Yeah, SUCs is kind of a special drug in pediatrics because, one, we always want it on hand for emergencies, but it also has some things that go along with it. First big thing is with that large volume of distribution, you're going to need a higher milligram per kilo for the initial dose for intubating. Typically, I would say it's 2 milligrams per kilo, where an adult, you might do 1 milligram per kilo, especially if you're giving an IM dose, 4 milligrams per kilo IM for, again, the IM dose. And then the big thing is to consider and possibly pre-treat the patient with atropine or glycopyrrolate because of the bradycardia that can come along with SUCs. And just a little refresher, pharmacology, the SUCs molecule is basically 2 acetylcholine molecules. They bind to the neuromuscular receptors, but they also bind everywhere else in the body, so our muscarinic receptors, and that's how we can get some bradycardia with SUCs. And it can be pretty significant in children and infants. So I always pre-treat with something before I give SUCs in the little ones. Once they get a little bit older, I might not, but then you also have the black box warning that comes along with succinylcholine, and that is a hyperkalemic cardiac arrest that has occurred in the past. So we're always a little mindful when we're giving SUCs to patients.
Yes, and the risk of undiagnosed Duchenne's muscular dystrophy is the reason why we have that black box warning. The FDA restricts the use of SUCs in children only for emergencies. So like whether it's, I've asked a pediatric anesthesiologist in the clinical setting, like where do you draw the line with giving acetylcholine to pediatrics? Because, we have patients that come in that if it was an adult, we would give SUCs too. But generally speaking, he said it depends on how high of a risk of aspiration the case is. So if it's a very high risk aspiration case, he would give it to pediatrics no matter what. So patient safety is number one, with this in the back of our mind that, again, it's that risk benefit analysis. Is the risk of the hyperkalemia associated with possible Duchenne's muscular dystrophy? Because children don't show signs of that until later, which is the whole premise behind why a smaller child or baby may have it and we may not know it, right? Because they don't show those signs until later. But if you have a baby and the risk for aspiration is much higher than the risk of Duchenne's muscular dystrophy, that's when you're going to give acetylcholine. So I've always kept that with me. And then laryngospasm, like you said, when we talk about the laryngospasm dose for acetylcholine, you said 4 milligrams. I think I learned 4 to 5 milligrams. I always remember 5. I keep that in the back of my head when I give peds because high 5, we broke the laryngospasm. That's how I've always remembered it. And I don't know I hope that's helpful to listeners, but that's how I've remembered it. Let's talk about the non-depolarizers now. We can kind of go into that. Okay.
So like we talked about earlier with the non-depolarizing drugs like rocuronium, the volume of distribution is larger, so you're going to need a larger initial dose to start out with to get it on board, get it there. But they have more sensitive receptors, and so the drug may last longer. The effects are really kind of unpredictable. It sort of ends up balancing out a little bit with rocuronium, where the dose ends up being about the same as the adult dose because of the duration of action and the receptor sensitivity. Now, if you were giving rock for like an RSI, a modified RSI dose, I would go for the larger dose in a pediatric patient because of that volume of distribution. The unpredictability and the sensitivity at the receptors means you really need to be using a train of 4 monitor. I feel like we don't always use these as much, especially now that we have Sugamidex, people just give it. But to know when you should be redosing the drug, you should be checking your twitches.
Yep, just like with any patient, just like with an adult or anyone, we're checking twitches and treating accordingly. But I always think of, again, that volume of distribution being a water balloon. I love how you said that. Because if you had a big pool and all these receptors on the side, it's going to take a big dose to get to those receptors. So I love the water balloon analogy and how you mentioned that initial dose to get to those receptors is going to be more in peds. So I was at CHLA for my rotation as a SRNA, and I was, again, lost, like mentally and physically in the facility. But I remember there was like a 2-week-old lap pylo at the end of the day. And I remember the nurse was like, "Oh, Chloe, are you going to be doing that case or is it going to be a fellow?" And I was like, "Oh, for sure it's going to be a fellow. Like, I'm not going to be doing that case. It's my second week." And no, it was me. So I did the case, and I'll never forget, the attending anesthesiologist was with me, and then she left for the case. The case is so short. When I say it was like... So short. And I had my reversal agents in TB syringes because this baby was so tiny. And I remember the anesthesiologist came back and I was like, "Can you check these for me? Like, I want you to check the dose and to make sure everything's correct before I give it to this tiny baby," because the case in and of itself was so short. And we had given, the dose of rock. And I wanted to make sure that the patient was adequately reversed from that dose of rock because it can hang out a little bit longer. And that's how it kind of ties into the pharmacodynamics of the non-depolarizers, is that it was going to hang out a little bit longer. So as a student, one, it's always good to ask questions, never feel stupid. It's always patient safety first. And I was so grateful for that. I'm sure she thought I was crazy because I was like, check these with these two, with neostigmine and glycopyrrolate in TB syringes. So now I say, like, if I'm pulling up anything in a TB syringe, like, I want to go home for the day. So I'm sure you're the opposite, where you're like, "Ooh, this is what I love to do." And a lot of providers, even, like I said, seasoned providers, seasoned, residents, fellows, like, it's all based on how much you do these things and the comfortability of it and the asking questions. So I hope all of our listeners learn from this anecdote and from everything Becky's saying today. Take it into clinical practice, ask questions, and stay curious, because that's what keeps patients safe at the end of the day. So it's all about age and physiology and context to whatever you're doing, whether it's a 5-minute lap pylo on your second week of peds ever. So now we'll talk about that. I think we're going to go straight into that. So let's talk about, I already spoiler alerted this one, I guess, but let's talk about a 4-kilogram term neonate for a lap pylo. What would your anesthetic considerations be, or kind of talk through an anesthetic plan for that type of patient and procedure?
So if you haven't had your peds rotation yet, a lap pylo is to treat pyloric stenosis. So they're basically not passing much food through their stomach, so they are a full stomach, 100% full stomach. This is a rapid sequence induction always, and you want to be careful when you're ventilating. The other big thing to consider with these patients is they're usually in a hypocaloric metabolic alkalosis, and pyloric stenosis is a medical emergency, not a surgical emergency. So the patient should be medically managed before they're brought to the OR. Is that always the case? No. So check your labs, make sure their lab work looks good before you put them to sleep. The big thing with these patients, they haven't been getting good nutrition. They're really weak. So we're going to do the RSI. Usually with where I just came from, they were really quick when maybe 15-minute surgeries. I've worked in teaching institutions where they're 30. So you balance that. So either rock or sucks, but you again have to balance the timing of those. And really, really short-acting opioids or avoid opioids. I personally would avoid them. We would go to sleep RSI and often give sometimes they would give IV Tylenol if you have it in your facility. The last place I worked was a little cheap and didn't want us to give IV Tylenol. But I wait until after the surgery, the patient's breathing and extubated before I give the IV opioid, because they're so weak, they have so much respiratory depression with it, that you have to sort of balance having them too deep and not want to wake up.
Yeah, so I did kind of spoiler alert how short the case is, and my anecdote would have fit. I actually kind of fit perfectly in between the two. But that patient did have hypochloremic metabolic alkalosis, which is again, boards, like the alarms can go off. This is like something you need to remember because it does happen. I don't believe that they had corrected it in this specific patient from what I recall, like 10 years ago. But we also did the awake OG2.
Suctioning. It's one of those things, if you're new to peds, it seems a little stressful and like, why are they doing this to this baby? But usually you take some sort of suction catheter and suction the stomach out. One of the anesthesiologists I worked with liked to do the 4-point suction. So he would suction supine on the left side, on the right side, and then flip the baby all the way prone and just make sure all the formula's out. And you will get a lot of formula from these babies because they're not passing it.
Yep, and I totally agree with you. I've always done that in my practice personally. Whenever I've done these cases, I think I've done 2 or 3 total, but so like not the expert. But yeah, we've done, I like you said, that 4-point positioning, because that's exactly what we did, all 4. And it's stressful because the baby's screaming, the baby's crying. Who likes to be fully awake with that? However, like you said, it sounds so weird, but we're a bunch of weirdos in anesthesia anyways, but it's so satisfying because, you will be like, oh, there's nothing left in this baby. There's nothing left. You flip them prone and you get a bunch back. So it's that feeling of like, oof, better out than in, especially for a high risk, aspiration type of situation. You definitely want it out. So yeah, stressful, but those are my pearls for this case that I remember, because obviously I have a little bit of PTSD from this at CHLA. So the second case, let's kind of talk about an anesthetic plan for like a 20-kilogram preschooler that's coming in for a tonsillectomy.
So for a tonsillectomy, they're obviously there, well, maybe not obviously, but they're probably there for OSA. So they have some sort of sleep apnea or chronic infections of their tonsils. So it's really important to not overdo the opioids again, because they can have some sleep apnea afterwards as well. And so that's one of the big things, is to try to avoid high dose opioids and really look for different multimodal ways to treat this patient. I like to do IV Tylenol. We always give them some sort of steroid, so they get a big dose of Decadron. Sometimes the surgeon will give some lidocaine to the area. I haven't worked with many that like to do that because they feel like it causes bleeding and they don't want to do anything with bleeding. But dexmedetomidine is great for these cases because it doesn't mess with all the respiratory centers, and so the patient will breathe well but be comfortable. The other big thing is to remember that the MAC is going to be higher than our adult patients. These are pretty stimulating procedures where they basically do like a laryngoscope to hold the airway open, and so it's really stimulating. So you're either going to need higher gas or propofol to get the patient asleep and comfortable. And then the big challenge with TNA surgery is the emergence. Waking them up can be a little spicy. I always have propofol drawn up and ready to go for these patients. With TNA cases, I always have propofol and sucks drawn up, ready to go.
Yeah, definitely for these cases, because of the bleeding risk and that blood dripping down on the cords and possibility for post-extubation laryngospasms. Knowing I always have, people have made fun of me before because I write the kilogram weight of the patient. I am an IV dose of sucks, and then as we know, it's 0.02 milligrams per kilogram of atropine. And I have that, whether it's IV or IM, it's the same dose. I have that out. Like I almost take one of the dance cards. I call them the dance cards when you help the surgeon scrub, and I write it on there and I like tape it to my anesthesia machine. It's so important to honestly get over your pride, have the doses ready, know what you're going to give. And I actually put the mLs with it as well so that I know. I'm one of the ones that draws it up like very specifically. So anybody that could come and could help could just push the whole syringe and it's the correct dose. But I do have the the milliliters as well so that everybody knows how much to give this specific patient.
I think that's so important to know and remember that you might not always be the one giving the emergency drug. So knowing for especially pediatrics, the milligrams per kilo, but also the mils, because when you're telling the circulating nurse, give 10, she doesn't know what that means. She's not given 10 of sucks before. So you really need to be specific and you need to know what they should be pushing and watching them.
Yeah, exactly. And even, I'm going on a tangent here, but for pediatric patients, I draw propofol up in no more than 3 milligrams per kilogram dose. And that's because if anybody came in and gave any stick of propofol to my baby, kid, toddler, whoever it's on the OR table, that patient would still be okay, right? If you have a 10 ml syringe of propofol for a tiny baby, like that could be catastrophic. So I always draw up medications, again, like you said, for patient safety reasons. If you need a circulating nurse to give 20 milligrams of propofol and she thinks that means 20 mLs of propofol, huge catastrophic difference. So I love how you mentioned that because especially in pediatric emergencies, things can go south really quickly and having those things in place really increases patient safety. So I love that. I was also going to mention in the place that I've practiced previously with pediatrics and tonsils specifically, we started off by we were trying the non-opioid approach. Again, like you said, a lot of these patients have OSA and we don't want to give narcotics for such a short case. They just don't need it. And so we started giving 0.5 of Precedex to every patient. And then we realized that they were still staying in recovery for a really long time. Although they weren't, the respiratory depressive effect wasn't there because of the Precedex versus opioids. But we decreased it to 0.25 mics per kilogram. And we found that was the sweet spot. Again, depends on your surgeons, how long they take, how comfortable your recovery room nurses are, and the patient population in your area. So we realized that was too much. And so it's all about altering based on what you see clinically. But that's worked out pretty fabulously for patients where I've worked. So. And
you can always give more. You can't give less. So start with the 0.25 and then go up if you need to.
Exactly. Or if they're waking up crazy, propofol is my go-to because I'm more comfortable with it for emergence delirium. But, Precedex is a great choice for emergence delirium as well. So giving more on that end is another option as well. I hate how we say it's like skinning a cat. It's just such a weird analogy. Like we need to come up with something better. But there's so many different ways of doing anesthesia. As long as it's amazing how patients can be safe with a bunch of different types of anesthetic plans, which is great for us as providers. I love talking to you and hearing your experiences. We don't see each other clinically practice, right? We know our facility really well, but like other facilities practice so different. I'm sure it's the least favorite thing for students because they're like, every provider does this so differently.
Yeah, it's hard. And that's why it's so important, especially in peds, to communicate well with your preceptor because sometimes they'll say things that don't really make sense to you because the way you did it yesterday is completely different. And so I always just like to clarify. I try as the preceptor to say, hi, I want you to give 10 of propofol. And by that, I mean 10 milligrams, which is 1 cc versus kind of giving vague responses.
Yeah, and I think it's very important. Again, I can go on a clinical tangent all day, but I was a clinical coordinator prior as well. So I had a lot of conversations with students, but especially in peds, it's so stressful and overwhelming for students. They have a lot going on. Were you in peds? Were you PICU or NICU prior? Okay.
PICU.
PICU? Okay. So a lot of us, that's why you love peds. No, it's all coming together. But a lot of us just did adult ICU. And by I say just, like the CT ICU nurses are going to come for me. But, we don't have a vast experience in peds. So on top of being stressed, preceptor dynamic, plus doing something totally different with patients because we did adult ICU, all reasons why over communicating is always would rather have a student that over communicates and you're like, okay, you're good. You don't have to communicate so much than the opposite. So again, patient safety is key in that regard. So let's talk about like some main take homes for the pediatric population. What do you think? Give us the heavy hitters here.
So the big take homes are neonates or water balloons. So volume of distribution is going to be high. They have low protein binding, so you're going to have a lot of free floating drugs that are highly protein bound drugs. And they have a leaky blood-brain barrier, so things are going to get to their brain faster. They also have usually slower clearance and excretion, so drugs are going to last longer than they typically would in your adult patients. So start low with your dose, go slow with things. You can always give more, you can't give less.
You can't take it away. No, I love that.
Right.
Let's talk about your app for a second. So you have an app, right?
I have a pediatric anesthesia drug calculator. So because I've done peds for so long and I see providers come in that are a little uncomfortable, I created an app that does the calculation for you.
So how does it work? You put in the kilogram weight, or?
You put in the weight, you hit save, and it will calculate all the dosage for you. It gives you reference ranges for each drug as well, so you know what the milligram per kilo dose would be. There's a few other things in there like ET tube size, IV fluid rates, maximum allowable blood loss. That's a big one.
What is it called? Yeah, that's a good one. The Mabel? Yeah. You call it Mabel? What else did you say? Oh, you said CYP. You called it SIP, the SIP enzyme. I'm going to call them SIP enzyme. I've never heard anyone call it that. Maybe I'm just too new to pharmacology education, but I'm going to keep that. So SIP and what was this one? What did you just say? Okay, whatever.
I don't know.
It was another acronym. It was cute. I love that. I love little shortening of phrases. So what is it called? How can people get the app?
You can go to pediatricanesthesiacalculator.com and that will take you to the App Store or the Play Store. So it hits both. I think it really is a good way to double check your dosages. I will say, as our nurse anesthesia residents, you need to know these dosages. You do not need to rely on an app in an emergency. You do not have time to get your phone out and start putting things in your phone. So I say Sux, atropine, epi, you need to know those dosages off the top of your head. The other dosages you can check in an app. That's fine with me. But those emergency drugs, you should know.
So this is you, right? This right here?
Yeah, that's it.
That's so cute. So I went to the website here and then it says, Google Play and App Store. So that's so cute. What a great little resource to have. Thank you for sharing it with us. And I totally agree with you. You should have all of those emergency doses. All of the doses you should have memorized throughout your pediatric rotation. And it gets easier day by day because you're going to be calculating them for each patient. So it becomes second nature after a while to just know how much to give, and you just start to memorize it on your own once you're in your clinical rotation, but definitely don't need a calculator for that. So we're going to end off by doing what I always do on this podcast, which is give a piece of advice to an anesthesia learner. So we're going to even go a step further and say, what is one piece of advice you would give to someone their first day in their pediatric rotation? They're feeling really overwhelmed. What's kind of a pep talk you would give them?
Always like to tell them, don't be nervous, but be cautious. You're going to want to be vigilant with these pediatric patients, but you shouldn't be scared of them. I always make the students laugh because I say kids bounce back really fast. They might desaturate quickly, but they also bounce back quickly. If something happens, they usually come back from it really quickly, where the 90-year-old might not. So we're not going to let you hurt the patient. You got this.
I love that. No, it's so important. Yeah, I think staying curious and knowing your resources, feeling comfortable, communicating with preceptors is key in peds. But like you said, it will come with time and you'll get it. You'll get there. Yeah, I always tell students too, it's amazing to see their progression from the first day of their peds rotation to the last day. We do 2 months of peds in the program that I went to, and then I was precepting students. And did you do 2 as well? 2 months of peds? Mm-hmm. Okay, cool. So I think it makes such a difference at the end. You're fully comfortable because you've done so many different, at CHLA we had a great experience clinically with peds and a lot of numbers of different types of cases and ASA classification. So the more experience you can get, the more questions you can ask, the more comfortable of a provider you'll be in the future when you become a CRNA, which will happen. Feels like it'll never happen, but it will. So I appreciate your time. Is there anything else you want to say or highlight for us?
Be patient with yourself, but be patient with your preceptor as well, because a lot of us peds CRNAs are a little extra and nervous. And so sometimes we come across as a little much and very intense, and it's going to be okay. We're both going to get through it.
I love that. That's so true. But as anesthesia providers, I feel like we're all, like I said, a little bit weird and have our little quirks, but definitely good to keep in mind too. And I always tell students, it may not be about you. It may be about the preceptor, what they've got going on. So I love all of your tips and your knowledge. Thank you so much for being with us today. I appreciate all of your time. Okay, cool. We'll have to do this again, do another round of it in the future.
Absolutely.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.